Hi, everyone. Welcome to our Glow Derm webinar series. We'll go ahead and get started here today. We have two amazing speakers who will be talking about dermoscopy today. Um, Before we begin, we just kind of wanted to introduce who we are. My name is Neha Sohail. I am a third-year medical student at Texas Tech, and I have my co-host here today, Dr. Alexis Strahan, who is a PGY2 in dermatology at Harvard University. So a little bit about the GlowDerm Trainee Committee. We are part of the International Alliance for Global Health Dermatology under the International League of Dermatological Societies. Our mission is to provide knowledge equity by enhancing access to dermatology education worldwide. And the way we do that is through different key initiatives. Our first is through educational webinars like the ones we have today, which is just free, high quality learning opportunities. We also want to shine light on networking and collaboration, so connecting trainees worldwide. And then, of course, the podcast series where we address challenges in global health dermatology. And then just as far as like meeting etiquette goes today, just make sure that your audios are turned off, your cameras are turned off. And then if you all have any questions, you can use the chat function or the Q&A function to send those off, and hopefully we'll be answering those at the end of the webinar. And then we'll share more about the GlowDerm Training Committee as well in the chat function. And so today we have two amazing speakers, like I already mentioned. We have Dr. Rebecca Hartman. She is an assistant professor of dermatology at Brigham and Women's Hospital and Harvard Medical School and chief of dermatology at the VA Boston Healthcare System. She earned her MD from the University of Pennsylvania, completed her residency at the Harvard Combined Dermatology Program, and received an MPH in health policy from Harvard. Her clinical and research focus is melanoma and skin cancer prevention, diagnosis, and treatment. She's authored over 80 publications. She receives funding from the VA, Department of Defense, and industry sponsors. She also serves on the Melanoma Research Foundation's board of directors. Our second speaker is Dr. Nicole Trepanowski. She is a PGY2 resident in dermatology at the University of Massachusetts. She earned her MD from Boston University School of Medicine and completed her undergraduate training in biochemistry at Northeastern University. Her clinical and research interests include melanoma, high-risk skin cancers, and cutaneous lymphoma. She is passionate about combining community service and dermatology. She has hosted several Women's Dermatologic Society shelter initiative events and volunteers in local free derm clinics and community skin cancer screening initiatives. So without further ado, I will hand it over to our two wonderful speakers. I'm going to go ahead and stop sharing. I'll let you guys go ahead and share your slides.
Great. Thank you so much for having me. Such a pleasure to be here to talk about dermoscopy and with my amazing mentee, Nicole, who worked with me for a year as a research student and helped publish a dermoscopy book chapter with me. Um, Let me just get into the right view. Great. Um, So I have the following disclosures, none of which are relevant to the content of this talk. And the goals today, I'm going to discuss the principles of dermoscopy. We'll talk about dermoscopic features of common skin cancers, as well as an algorithm that can help you in clinic seeing patients with your dermatoscope. We'll talk about a couple other lesions and their dermoscopic appearance. And then we'll have a case-based discussion led by Dr. Trepanowski. So why do dermoscopy? Well, we know skin cancer is often easily curable when detected early. Obviously, these are two extreme cases of advanced basal cell carcinoma and a stage 3 acral melanoma. But we know that survival for melanoma in situ, or even the earliest stage of melanoma T1A, 5-year survival is 98%, so it's approaching 100%. And they basically have a curable disease, where if unfortunately the disease becomes more advanced and it's detected later, the outcomes are much worse. And dermoscopy can help in early detection. So this is showing the evolution of a basal cell carcinoma from the initial presenting appearance of kind of a pink patch. Maybe we're unclear on the diagnosis. Is it an AK? Is it inflammatory? And then developing into more of a nodular basal cell, although still detected at quite an early stage. And so there's data, there's evidence to support use of dermoscopy in that it reduces the number of benign biopsies. So from 34 number needed to biopsy to detect a melanoma to 11. And when used to diagnose a melanoma, it's associated with earlier stage diagnosis. And also, I think one of the biggest benefits is it can be reassuring for a benign lesion. So this patient presents with a pigmented lesion on their eyelid. This is a cosmetically challenging site to sample, but we can see the dermoscopic appearance is reassuring. There's a benign globular pattern associated with the nevus and terminal hair growth. So we don't need to do a sample, which is great. So what is dermoscopy? It's a non-invasive handheld device with up to 10 times, I think actually some of them can do 40x magnification and polarization. As I mentioned, it reduces the number of biopsies to detect melanoma. It can aid in triage and improve early skin cancer detection. The downside is it does require a significant training. And just for all our trainees out there, I was definitely once a trainee. I think sometimes you get a little bit worse actually before you get better as you learn how to use this device. So because you're kind of looking more closely and you may end up doing more biopsies, but usually that evens out over time as you practice. So this is just showing like a melanoma clinical view and then the additional information gained from the dermatoscope, which is tremendous. So we're going to go over all this, but you can see many melanoma specific features here, like white crystalline structures, eccentric away from the center blotches of pigment. You can see reticular networks, so you know it's a pigmented lesion. And it's extremely irregular and chaotic, so very concerning for a melanoma. How does dermoscopy work? You start with a light source. There's always a polarizer at the light source. The light source is shined into the skin. There's it's optional to have contact dermoscopy with the liquid interface. We'll talk about that in a moment. And then the light comes back to the viewer, and it may or may not be viewed with another polarizer when you come back and view it. And this helps us basically see underneath the surface of the skin. And we can see different colors. Based on kind of where structures lie on dermoscopy. So black is actually often just in the surface scale crust. Brown can be at the DEJ. Gray and blue are deeper colors in the dermis. Yellow is also scale crust. White or scar is deeper in the dermis. And then red blood vessels are deeper in the dermis. So how to use dermoscopy? There are actually three ways you can use. This is an example of a dermatoscope. Several companies make them. You can use it in non-polarized contact dermoscopy. So that is contact, meaning the glass plate is in contact with the skin. Polarized contact dermoscopy, I highlighted that because that's where I live usually. I think that I'll show you why, but I think that gives you the best balance of kind of everything. Um, and then polarized non-contact dermoscopy. So you still have your polarizer on, but you have this plate retracted and you're not coming in contact with the skin. I think most, at least most dermatologists I see in the US practice in that way. It is kind of nice because the contact, you have to clean it in between patients. So it can be helpful not to have the contact aspect. But when you do contact, technically you need an interface. I use that with an alcohol swab. Some people use a gel or oil. And just showing what polarization offers, many of us know from sunglasses, but it just helps you kind of get rid of a glare and see more deeply. So looking at a stream of fish without the polarized sunglasses and then with the polarized sunglasses, you can see a lot more detail underneath the water when you have the polarizer on. And so this is a paper from Dr. Ashmar Goob, who really is one of the founders of dermoscopy and a world leader. And a lot of our learning comes from him. But just showing how different structures can look on non-polarized um, contact dermoscopy, polarized contact dermoscopy, which is, I told you that's where I live, and polarized non-contact dermoscopy, which is where I think the majority of dermatologists in the US practice. And different structures will basically show up better depending on which of the three modes you're using. Non-polarized contact dermoscopy is really helpful to see milia-like cysts and comedo-like openings of an SK. And this is a seborrheic keratosis. This is just showing a picture of the polarizers off of an SK, and boom, the polarizer's on. All of a sudden, you can see these milia-like cysts and comedo-like openings. So really helpful there. And similarly, only with so this is when you, I'm sorry, turn the polarizer off. So polarizer's on and this is non-polarized. Now you can see all these structures of the SK. For shiny white structures, actually, you see them a lot better when the polarizer's on. So here the polarizer's on, we can see these crystalline structures of an amelanotic melanoma. But if our polarizer's off, we miss that. So I recommend typically having the polarizer on. You can do contact or non-contact if it's easier. And then if you're considering like a seborrheic keratosis and really want to see the milia-like cysts and comedo-like openings, just click the polarizer off and you'll get a better view of those. So context matters, I think. We actually at the VA do a lot of teledermatology and teledermoscopy, but I do think there's always things to be gained if the patient's in front of you, because you can learn about their age, their skin type, the distribution of the lesions, and your clinical impression. So this lesion in isolation might look like a squamous cell carcinoma in situ on the dermatoscope, but if you see the patient, the whole patient, you would know that they had psoriasis, and this is just one of their plaques of psoriasis. So I do think context can be helpful. The other thing to always consider is the skin phototype and what the patient's background is like. There's, as you all know, skin phototypes determined by melanin in someone's skin and how they react to the sun, both their burning and tanning response. And that I think influences the context a lot because someone with a darker skin type will make darker lesions, like darker nevi that are benign. And actually, what Ash Margoob says is a pink lesion in someone with a skin type 6, we should really look at closely because it's very atypical compared to their background. Whereas someone who's very fair, like a redhead or a redheaded person, skin type 1, anything dark in them would be, unusual. Most of their nevi are light brown or pink. So context definitely matters as well as the skin type. The traditional dermoscopic algorithm is quite complicated. So this is the two-step algorithm invented by Ash Margoob that I use in my practice, and I teach our residents at Harvard. But we spend like hours to learn this. So this is a 45-minute talk. I'm going to condense it and use a more simplified algorithm. But if you are interested in learning the two-step algorithm, the company Dermlight has really great videos on their website, these Vimeo videos of Dr. Margoob going over his two-step algorithm at a conference in two separate videos that are, a couple hours long. So instead, we're going to talk about a simplified algorithm called TADA, the Triage Amalgamated Dermoscopic Algorithm. And this has been really well studied in actually primary care providers. And it's been shown to improve the sensitivity of malignant lesion identification from 0.63 to 0.88 without significantly changing the specificity. So this is the TADA algorithm. First, we're going to look at the skin lesion with polarized dermoscopy, PD's polarized dermoscopy. If we see unequivocal features of three very classic benign lesions, an angioma, these are just schematics of what they look like, we'll go over it, a dermatofibroma or a seborrheic keratosis, then we can be reassured and reassure the patient it's likely benign. I mean, I always tell the patient if something's growing or changing, come back because, it's hard to be 100% diagnostically confident. But these are three pretty classic diagnoses. And then if we don't have features of those classic benign diagnoses, those three, then we're looking for if something's disorganized or not. Like, and disorganization, I think is great because it's like an intuitive concept, right? Is there good symmetry across multiple axes or is it really irregular? If it's irregular, we're going to biopsy or refer. If it's regular, but it has any of these features, we'll still think biopsy or refer. So that would be the starburst pattern, blue, black, or gray color, shiny white structures, which are only seen on polarized dermoscopy, negative network, which we'll talk about. These are white curvilinear structures between kind of pigmented, irregular pigmented globules, ulcer or erosion, or vessels. Then we'll consider biopsying, especially irregular vessels. Um, there are caveats with the algorithm. It's not great. It doesn't work on the acral surfaces, palms or soles, mucosal surfaces, and nails. It's best to be able to use polarized and non-polarized, since as we talked about seborrheic keratoses, the milia-like cysts and comedo-like openings are best visualized on non-polarized. Patients should always continue monitoring, as I mentioned, and report changes. Um, and then think, in terms of disorganized, we're thinking about the colors and the structures of the lesion. And monitoring, you can do several different things. You can tell them to self-monitor. If you're worried about a lesion, you can do short-term mole monitoring, which we typically say is 3 months. I only do that for flat lesions. And the reason is if you're worried about something nodular, especially like a nodular melanoma, then 3 months is too long to wait. Okay, so we're going to talk about these three classic benign lesions first, the cherry angioma, the dermatofibroma, and the seborrheic keratosis. So I think it's really helpful to have the clinical and dermoscopic correlation. So this may be banal review, but we'll do the clinical of these lesions and then the dermoscopic. So cherry angiomas, we know, are these bright red papules or macules. Often you'll see several. So this patient has several on his back. Sometimes they can be more raised. On the scrotum, there can be these angiokeratomas, which can be more violaceous or a little bit darker in color. And these are just benign blood vessel growths, and the dermoscopy reflects that. So what you see is lacunae or lakes of blood separated by white septae. And the colors can be variable, especially with the angiokeratomas. You don't just see red, you can see maroon, blue, or black. So this is a good example of an angiokeratoma where you're seeing several different colors. They can definitely be more violaceous, and then they can be more bright red. But the key feature on dermoscopy is that we're seeing there's good symmetry, right, throughout the lesion. The pattern's somewhat homogeneous throughout the lesion. And we have these lakes of blood, whether that's red, blue, or black, separated by these white septae. And so this is reassuring. You can reassure the patient it's benign. Dermatofibroma clinically, I think this is one actually where it's harder on telederm because I really feel like the firm texture in clinic is really helpful. They're very firm when you feel them. There's really nothing else in the skin, in my opinion, that feels quite that firm in terms of typical skin lesions. So they feel very firm. They can be in someone who's naturally more dark, deeply pigmented. They can be quite dark in color, dark brown. And someone who's has a lighter skin phototype, they can be more pink. Um, they can have a central scar-like appearance. And the dimple sign, about 90% of them have the dimple sign where if you apply lateral pressure on either side, the lesion will dimple. But not all of them have the dimple sign, so something to note. And then what do we see on dermoscopy for a dermatofibroma? They have a very classic appearance, and if you start to look at a lot of them, then you'll really get comfortable with it. They have a peripheral fine reticular mesh-like network that's seen in this cartoon, and then we also can see that in several of these examples. Peripheral mesh pigment network. So that's interesting because typically we associate that with a melanocytic lesion, but dermatofibroma is one of those exceptions. That's why it's early in the algorithm where they can have a peripheral reticular network, but it's not truly a melanocytic lesion. Um, and then central white or pink scar-like area, because dermatofibroma, as we know, is like a benign scar-like tumor that can happen, potentially the theory is like at a site of trauma. Um, so the central scar can be seen here. So you'll see white structures, which again, white structures are only seen with the polarizer on. And all of these examples have central scar area. Some more of like a homogeneous white scar, some more with kind of crystalline structures, white lines that are perpendicular. And then ring-like globules. So you can see these brown circle structures in a dermatofibroma. And then they can have dotted vessels centrally, which I think we see a few here. Sometimes vessels are harder to see if you have the contact dermoscopy. So it's helpful to actually go into the non-contact mode because the contact can blanch the vessels if you're trying to look for vessels. So that is the typical dermoscopic appearance of a dermatofibroma. Again, across different skin types, they could be darker if someone's natural skin tone is more dark, and they could be more pink if someone's natural skin tone is more fair. And then seborrheic keratoses, as we know clinically, they can have a myriad of appearance and can be very concerning to patients and generalists alike. But there are these warty stuck-on plaques or papules. Sometimes they're macular or flat as well. They can be very, very dark in appearance or more pink. Often patients have many. And on the face, we can get DPNs, a variant of dermatosis papularis nigra of seborrheic keratoses as well. And so what are we seeing for seborrheic keratoses on dermoscopy? As I mentioned already, the milia like cysts, those can only be seen with the non-polarized dermoscopy. So here's an example. Again, we have a seborrheic keratosis with the polarizer on. Boom, we turn the polarizer off and we can see these milia like cysts much better. And Ashmar Guboy says at least 3 milia like cysts to confirm a diagnosis of seborrheic keratosis because you can actually see milia like cysts in other entities like dermal nevi or basal cell carcinomas. So you really want to see at least three. But the comedo, I will give a caveat. The comedo-like openings, although suggest so comedo-like openings are these kind of pore-like openings that you can see better again with the polarizer off in the seborrheic keratosis. Those are not 100% for seborrheic keratosis. You can rarely see those there are kind of some melanomas that have an SK-like appearance. But 3 or more milia like cysts, Ashmar Gub says 100% for seborrheic keratosis. So I'm always reassured when I see that. This is the cartoon of the milia-like cyst. They're these white spots that look like milia within the lesion. Sharply demarcated borders, they tend to have a sharp start and stop, as you can see here. They can have the comedone-like openings, which we talked about, the kind of little invaginations, little pores within the lesion. They can have fissures and ridges, so they can kind of have this like brain-like appearance where you have these gyri and sulci within the lesion. They can macular seborrheic keratoses, so more flat, can have these fingerprint-like areas. So if you look at this example, it's not a true mesh reticular pigment network. Instead, it's these lines that look more like the dermatoglyphs that make your fingerprint up. They can have these hairpin vessels. So those are pink kind of U-shaped vessels, typically surrounded by more pink rather than surrounded by white, which is different than squamous cell. We'll talk about that in a moment. This is a schematic of the hairpin vessels. And then they can have these moth-eaten borders where, just like if a moth ate a bit of clothing, they can have little kind of invaginations in the border, but they still have a sharp start and stop. So just showing several different, I mean, it really, as you guys probably know from clinic, seborrheic keratoses can look like anything, but they do kind of have these general features, which are reassuring on dermoscopy. And then we're going to cover just some of the appearances of skin cancers as well now. So talking about melanoma, so clinically, the classic description of melanoma is like an irregular pigmented lesion, whether it's a macule, a patch, a papule, or more of a nodule. These are just several different examples. This is actually an SK-like melanoma that I diagnosed, but you can see how this crusty part could look more like an SK. This is an acral melanoma, so we're looking for an irregular pigmented lesion on the palms or soles, as well as the nails. Another example, the classic description on a nail clinically, right, is a band more than 3 millimeters wide and then irregular in shape. So perhaps like triangular, not necessarily rectangular. You can see nail dystrophy. You can see pigment on the skin of the nail. That's called Hutchinson's sign. Um, nail dystrophy, several different aspects of nail melanoma. That's part of acral melanoma, irregular bands of different colors. And then I want to highlight amelanotic melanoma, which is tricky because it looks pink and often mistaken for a basal cell, but it can happen. A lot of cases of amelanotic, they often have some pigment too. So I would say pink plus brown, look at it twice, but they can be just pink, especially in very fair skinned individuals like a redhead skin phototype 1. And then lentigo maligna, a subtype that can happen more commonly on the face, chronically sun exposed, an irregular brown patch on the face. So thinking about dermoscopy for melanoma, there are several kind of melanoma specific features on dermoscopy that we want to look out for if we're looking at a pigmented lesion. The first one is the atypical network. So we discussed how kind of a reticular mesh-like network is typical of melanocytic lesions, although also seen in a dermatofibroma. But in melanoma, it's always like gone bad. So it's an atypical network that's kind of thickened and irregular. It's not that fine mesh that's the same color throughout and the same size. It's these thicker, irregular, darker lines. And then on the face, for lentigo maligna, you can see this kind of angular rhomboid structures of the irregular network they look like rhomboids. They make these geometric kind of shapes surrounding the hair follicle, and they're darker and they can be asymmetric. Streaks are pigmented structures at the periphery of the lesion. Um, they can be radial streaming, just streaming out, or they can be pseudopods with little club heads at the end. Eccentric blotch, meaning a deeply pigmented area that's not in the center of the lesion, although with nodular melanoma, it can be more symmetric and in the center. Here's an example where it's eccentric. You also have some ulceration. Atypical pigment globules. This is a good example in this amelanotic melanoma, but we have these irregular pigment globules that are asymmetrically distributed in the lesion and asymmetric in color. Some are very dark, some are lighter. Regression, so white areas where the immune system has tried to fight the melanoma and there's scar. Blue-gray veil, remember in our colors signify where in the dermis we are or where in the skin we are, the epidermis as well. So blue-gray means we're deeper. So that's indicative of a deeper melanoma that's in the dermis. Atypical vessels, there are myriad in the interest of time. We're not going to present them all, but you can see dotted vessels, serpentine vessels, linear vessels. Crystalline structures is an important one with the polarizer on. You can see these perpendicular white orthogonal lines in a melanoma. And those perpendicular white orthogonal lines are really only seen in two other entities, these fine white perpendicular lines. And those are in dermatofibromas, which we talked about, and Spitz nevi. And then in more macular melanomas, you can see peripheral brown structureless areas. Two other things to highlight for acral melanoma, we're looking for the parallel ridge pattern where the pigment is on the ridges, where the acrosyringium are, rather than in the furrows or the creases. And then the negative network, which I forgot to mention, I'm sorry, which is one of the atypical network appearances. There's another example of negative network here and another example here. It's these white irregular structures. It's not quite the same as the normal reticular peripheral network, but it's these white irregular structures surrounded by irregular kind of pigment globules. But you kind of see almost a white mesh network, and that's always concerning. That's a sign of a negative network in a melanoma. And then thinking about basal cell carcinoma, so clinically, again, we have several different appearances. For superficial basal, it can be more of a scaly patch or an eroded patch. Usually, sorry, scale's like more minimal compared to squamous cell carcinoma in situ, which we'll talk about next, although you can have a little bit of scale. You often do see pinpoint erosions. In deeply pigmented individuals, you can get pigmented basal cell carcinomas, which can be quite dark. And I think without dermoscopy, it's really hard to differentiate versus a melanoma, but dermoscopy helps me do that. And then you can see pigment flecks here as well in this pink basal cell. They can be more sclerotic if it's morpheaform. And then the classic clinical description is a pink pearly ulcerated papule with rolled borders. So what do we see on dermoscopy? The dermoscopy always kind of correlates with the clinical, but we have several features here. One is the arborizing branched vessels or telangiectasia, shown beautifully in this photo. They're always very crisply in focus, and they have a very distinctive appearance of these fragile branching vessels because it is a cancer not growing normally. And I feel clinically very confident that it's a basal cell when I see these specific types of vessels because nothing else really makes these vessels. And that's associated with a nodular basal cell, so one that has a little bit more of an invasive component than a superficial basal cell. You can see these spoke wheel structures or concentric circles, which are kind of a circle within a circle. You can see leaf-like areas that look like maple leaves. I once got a question, how is that different than the pseudopods or radial streaming of melanoma? The leaf-like areas of basal cell go both in and out, whereas for melanoma, it only goes out from the edge. So that's one way to think about it. And then the blue-gray ovoid nests. So again, they can be very deeply pigmented and it's tricky. I will say they are usually not black, whereas melanoma can be a black. It's usually more a blue color is one way to distinguish. You can have these dots, which typically are described as buckshot scatter, meaning they're like haphazardly arranged, and they can be brown or blue-gray. Shiny white blotches and strands, so again, only seen with your polarizer on. They're different than the crystalline structures because they're not these perfect little lines, they're more blotchy. But that's very common in basal cell. And then ulceration, as you can see here, kind of corresponding to that ulcerated papule. Squamous cell clinically, we have a well-differentiated squamous cell here, keratoacanthoma, which is a pink kind of crateriform nodule with a keratinaceous center. You can have more of just a very keratinized nodule. For SECIS, pink scaly patch. Um, Again, another invasive squamous cell carcinoma, kind of more well differentiated. As they get poorly differentiated, they can be very hard to tell what they are because you just get this red friable nodule, and it's hard to know, is this a squamous cell or a Merkel or a melanoma? You have to biopsy it. On dermoscopy, I find of the three skin cancers, I think squamous cell dermoscopy is probably the least helpful, although still potentially helpful. Especially for SECIS, you'll see these glomerular vessels. They're called glomerular because they are involuted, kind of like the glomerulus of the kidney. And that's very classic for SECIS. And they're usually kind of evenly throughout the lesion. So there's good kind of organization still, even though it is a evolving early skin cancer. You can also see hairpin vessels, especially at the periphery of keratoacanthomas. So hairpin vessels, as I mentioned, can be seen in seborrheic keratoses. There are a couple of differences. In squamous cell, they're often at the periphery only, whereas seborrheic keratoses, they're on all the little ridges of the lesion with its gyri and sulci. And then they have on the squamous cell, they have a white halo. So they're usually surrounded by white, by keratin. Um, Keratin pearls are another feature. They're these white circles. You think about a squamous cell, it's making keratin because they're the surface cells of the skin. So you can see these white circles. You can see scale crust as shown in this lesion. And then rosettes are another feature only seen on polarized dermoscopy. So you can see the difference, polarizer off, boom, turn it on, they highlight. And they're these four-leaf clover structures. And they're really indicative of kind of sun damage. So you can see them also in AK or chronic sun damage, but they are also seen in squamous cell, usually more like an SCCIS. Okay, and then other interesting dermoscopic findings I thought that might be of interest to our group. So for Kaposi sarcoma, there's a report of this homogeneous pattern with several different colors. So you kind of have these homogeneous areas, but they can be some are more red, some are more yellow, some are more blue. There's this rainbow-like pattern that's seen on polarized dermoscopy where you turn on your polarizer and it almost looks like a rainbow in areas where you see several different colors. That can actually be seen in other entities as well, but that is the classic dermoscopic report of KS. And then for scabies, we're looking for the delta wing sign. I do find this really helpful for scabies. The delta wing sign, you see that kind of head of the mite is brown, and that's like the wing. And then there's like a contrail, like a jet engine putting out plume, and that's the burrow. So all the white scale, the contrail of the jet engine is the burrow of the mite. So you see it, the dark triangular head up front, that's the delta wing. I guess the triangle is like a delta. You see the brown body of the mite, and then you see the white scale, the contrail. And then pyogenic granuloma, this was one of my recent cases, this picture. You can see reddish homogeneous areas, white lines resembling rails. So it's not quite as nicely defined as the lacunae and septae of a cherry angioma. You have these kind of more obtuse, thicker white lines that they call rails. And then, of course, you can have a white collarette kind of surrounding the lesion, both clinically and seen on dermoscopy. Okay, that was a whirlwind tour of dermoscopy. You can do like a 5 hour seminar on it. I tried to cram it all in, and now we're going to do some cases to test what we learned, and Nicole is going to take it away. I can advance the slides if you want, Nicole, while you chat. Does that work?
Sounds great. Thank you. All
Oh,
right.
so, yep, go ahead, Nicole.
Okay, so then we're just gonna go over again. This is just that diagram that Dr. Hartman showed. So first, you want to look and see if it's an angioma, dermatofibroma, or seborrheic keratosis, and if it is, you can reassure and monitor. And then if it's showing architectural disorder or disorganized pattern, then you're going to biopsy refer. And then if not, you're going to look for those features of blue, black, gray color, and shiny white structures, negative network, ulcer erosion, and vessels. And if you do see any of those, then you would biopsy or refer. And if not, you would monitor it. Okay, so we have a 47-year-old man who has skin phototype 3 with a new growth on the nose. So we see on the left nasal ala, we see an eroded plaque with different pigmentation. There's a little bit of scale. So under dermoscopy, we can see maple leaf structures, arborizing vessels, ulceration, shiny white structures. So first you're thinking, is this a DF? Is it a seborrheic keratosis or an angioma? And we're not seeing any of those features. Um, so we are going to go down on the algorithm. So is it organized or disorganized? And it is disorganized. And then we're going to biopsy refer this because, like I said, we are seeing those features of basal cell carcinoma. So we're seeing chaotic distribution of structures and colors, which are those maple leaf structures, arborizing vessels, ulceration, and shiny white structures. Okay, next we have a 56-year-old woman with a bleeding papule on the right calf. So we see a bright red papule. So on dermoscopy, we are seeing lacunae separated by white septae. So first, we're going to go back to that algorithm, and do we see features of angioma, dermatofibroma, or seborrheic keratosis? So yes, this is looking like a cherry angioma, so we can reassure. So again, you're going to see lacunae separated by white septae, and like Dr. Hartman mentioned, you can see different colors, so red, maroon, blue, or black. And next we have a 65-year-old man with a brown growth on the left temple. So we see a stuck on waxy plaque. So looking at dermoscopy, we see some comedo-like cyst and some milia-like cyst. So going to the algorithm, is there findings of unequivocal angioma, dermatofibroma, or seborrheic keratosis? And yes, it is looking like a seborrheic keratosis. So this is going to be benign, and we are going to reassure. And again, just reviewing those features of seborrheic keratosis, you can see a pseudo network, milia-like cysts, crypts, hairpin blood vessels, comedo-like openings and fissures. We don't see all of these necessarily at the same time on seborrheic keratosis, but if you're seeing any of these and not seeing features of nevi, it's most likely a seborrheic keratosis.
Awesome. Thank you so much, Nicole, for running through those. I really appreciate it. I'm going to run through a few other cases and then we'll wrap up and take questions. Um, this is a 66-year-old woman, skin photo 2 with an enlarging brown macule on the left shoulder. We can see here from the clinical photo, kind of some irregular pigmentation, some areas lighter brown, some areas darker brown, somewhat large in size, and it looks flat. Here's a closer up of the photo next to two kind of obvious seborrheic keratoses. So we're on dermoscopy, we're going to try to run through that algorithm. Do we see clear features of a dermatofibroma, a seborrheic keratosis, or an angioma? I would say we do not. Is it organized or disorganized? I would say it's disorganized. So if we try to draw like axis of symmetry, we can't really fold it on itself. The colors are disorganized, like you have darker areas here, lighter areas here, a white area here. The structures are disorganized. You have some areas where there's what looks like a pigment network and it's thicker and atypical, and some areas where it's kind of more reticular and mesh-like in appearance, and some peripheral tan structureless areas. You even have a few globules hanging out. So it's pretty disorganized. So it's already bought us a biopsy. Um, so we want to think about why this is disorganized. We talked how the color and pattern is not uniform throughout the lesion. And this is not surprisingly a thin melanoma. And again, it's by the triage amalgamated dermoscopic algorithm, ta-da, it's it clearly would be a biopsy. But we also, if we want to use some of the features of the more advanced two-step algorithm, we see several melanoma specific features. So we see an area of regression here that's white. We see atypical pigment network, these thickened brown areas. We see irregular globules, pigment globules here and here. We see peripheral tan structureless areas. So we have several features of melanoma that are concerning in this lesion, and some peppering as well, these gray kind of dots, which are another sign of regression. 51-year-old man, skin phototype 2 with a history of melanoma and a new dark growth on the lower back. Look at this big scar. Context is everything. He has a prior history of melanoma. He also has many nevi or moles. And this is the lesion in question. So on dermoscopy, we're going to run through our algorithm. Do we see clear features of a dermatofibroma, a seborrheic keratosis, or an angioma? I would say no, we're not seeing the classic dermatofibroma pattern, which just as a reminder would be a peripheral fine reticular mesh network with a central white scar. You can see dotted vessels and crystalline structures on the polarized dermoscopy, as well as brown circles. Seborrheic keratosis, which Dr. Trepanowski highlighted, stuck on comedo-like openings, milia-like cysts, hairpin vessels, fingerprint-like structures and more macular lesions, gyri and sulci. An angioma, the red lakes separated by white septae. We're not seeing any of that. And then is it organized or disorganized? Again, are we seeing organization of the structures? No. We see some areas that are very dark and thickened. We see these white structures here, which I'll explain in a moment. And then what about the colors? The colors are also disorganized, dark brown, light brown, white structures. None of them are organized. It's asymmetric. Oh, they're actually saying, I guess we're saying it's organized. I don't think it's organized because of the white color and the dark brown, but I guess they're saying the shape potentially could be more organized. And then if you were to say this was organized, we're looking for any of the following features that would be concerning. And so these include shiny white structures, which we are seeing some white structures here, as well as negative network, which really I think a lot of this white is actually negative network, these white curvilinear structures separating pigment globules. So that's very concerning. So even if you felt, I personally don't think this looks that organized, but my colleague, I should give credit to Dr. Vinny Sieverling, who helped prepare some of the slides for this talk. She thinks it is a little more organized, but we're still going to fail, unfortunately, on the negative network. So we do need to biopsy this lesion. Um, it also has malignant, if you're using the two-step algorithm, it has several malignant features for melanoma. It has this blue, black, gray color, negative network, like we talked about, these hypopigmented serpiginous lines between curvilinear pigment globules. I would say it has atypical thickened network too in some of these darker areas. So it is concerning for a melanoma, and it is indeed a thin melanoma, zero point 0.2 millimeters. And these are the type of melanomas that I think with dermoscopy you'll diagnose as opposed to the naked eye, you'll diagnose early melanomas. And then one last case for us, a 56-year-old man with an enlarging growth on the temple, clearly pigmented. We put our dermatoscope on. We're wondering if we see features of an angioma, dermatofibroma, or seborrheic keratosis. I'm not seeing clear features of any of those. Is it organized or disorganized in terms of both structures and colors? I would say disorganized. We have some globules here, but they're not present really anywhere else, maybe down here. We have some white structures and red areas here. We have some darker areas here. So we have a lot of different colors and a lot of different structures. And so we would want to biopsy or refer this because it fails on the organized feature. And we do, again, using the two-step more advanced algorithm. If you have time to watch those videos from Dr. Margoob, you would see that this lesion has many melanoma-specific features. So it has irregular globules that are asymmetrically distributed in the lesion. It has negative network over here. You're seeing some peripheral globules over here and some thickened kind of atypical network over here, and maybe more eccentric blotches of pigment over here. And these will be highlighted here, the atypical globules, as we mentioned, maybe some eccentric blotches or blue-gray veil, and some of those shiny white lines that we see in melanoma, as well as some negative network over here. And that's all I had. I'm happy to take any questions.
Thank you both so much. That was incredibly practical and helpful. We do have a few questions. I'll scroll through them. The first one is, can you explain the difference between negative network versus shiny white structures or crystalline structures?
Yeah, that's a great question. And sometimes I think it can be tough. But the crystalline structures are only seen on polarized dermoscopy, and they're really like a bright white. I'll see if I can, maybe if I share my slides, I can show an example. Um, Whereas the negative network is more described as hypopigmented lines, and they're not these perfect perpendicular orthogonal structures. When we're talking about melanoma specifically, they're curvilinear. So let's see. This one I think had a good example. This is negative network. See these white, sorry, I shouldn't say white, hypopigmented curvilinear lines. And then for the crystalline structures here, they're more orthogonal and brighter white and these perpendicular lines. So I think both the shape and the color can be a little different. Whereas the negative network can be hypopigmented, the crystalline structures are bright white, only on polarized dermoscopy. And in melanoma, they're these perpendicular orthogonal lines, as opposed to the negative network, which is more curvilinear. Like kind of almost making like it's called negative network because it almost looks like the mesh-like reticular network of a melanocytic lesion, but it's not. It's hypopigmented, so it's like an inverse or negative network.
Okay, great. Our next one is, do you typically recommend oops, looking at most lesions with and without polarization to see the different structure types.
I'm sorry, can you repeat it one more time?
Do you typically recommend looking at most lesions with and without the polarization to see
Okay.
the different structure types?
That's a great question. So as I mentioned, I like polarized contact the best because I think you get the best blend of all the different features. If I go back and show you. But a lot of people live in the polarized non-contact because it's very annoying. The contact you have to clean each time. And it's kind of like time and resource intensive. This is polarized contact. I think it gives the best blend of all the features. But either way, I think what you should do is spend most of your time in polarized, whether it's polarized non-contact or polarized contact. And then I really only turn the polarizer off if I'm trying to look for an SK and I'm looking for the milia-like cysts or I'm sorry, I'm trying to get my pointer and it's not working. The milia-like cysts or the comedo-like openings that you can see. Let's see if I can get my pointer. So that's where I think turning off the polarizer is really the most helpful. Everything else you can kind of already see, um, especially if you're in polarized contact dermoscopy. Here saying the blue-white structures in the peppering can be seen better with the polarizer off, but really the only one with like the most that you can't see any other way as well is the milia-like cyst and comedo-like opening. So I'm on polarized, and then if I'm thinking about an SK, I turn off the polarizer to look for those features.
Okay, great. That makes sense to me. Um, okay, we'll do two more and then we'll wrap up. What resources have you found helpful? Maybe this is a good question for you, Nicole, as you're going through this. Resources you found helpful practicing these skills, maybe for patient or people who also don't have as much regular patient interaction to do it on the job. Are there any other resources that you found to be helpful to practice maybe the algorithm or specifics like that?
Definitely. I think at the beginning, it's looking at a lot of benign lesions as well, things that you already know clinically. They definitely look like an SK, it definitely looks like a cherry angioma, and really getting a sense of what that looks like under the dermatoscope is very helpful. But if you're not working with patients, going to webinars like this or the AAD, if you go to that, has some very great dermoscopy lectures. It's like dermoscopy for beginners. They have intermediate, advanced, which I think are also super helpful as well. And then lots of resources in terms of different textbooks, for example, like the one I got to write with Dr. Hartman. We wrote a textbook chapter on dermoscopy, but there's plenty of resources online as well.
Thank you, Nicole. That was a great overview. The one other one I'd like to echo, I really think those videos on the Dermlight, and I have no COI with Dermlight, really any brand of dermatoscope's great, but they have these videos recorded from Ash Margoob's lecture at like a Maui conference. And I just think those videos are amazing. Like if you watch them, they're really, really helpful if you want to learn the two-step algorithm and really advance your dermoscopy skills. And then Ash Margoob also has one other. I'm an Ash Margoob acolyte. He's my dermoscopy leader. If you only, as Nicole was saying, if you only look at things you're worried about as malignant, you'll only improve your sensitivity. So to also improve your specificity, you should throw your dermatoscope on something that you clearly think is benign. And I think that will help you understand what like an SK, cherry angioma, dermatofibroma look like. So that was a great tip from Nicole.
That's great. And then you kind of alluded to this answer to this last question, but do you have any specific dermatoscopes that you like or recommend in terms of either optical quality, clinical utility, or are any of them great?
That's a great question. And so I sound like again, I have no COI. I've only used Dermlights. That's the only one I know. I think they're the biggest brand, so they have a lot of recognition. But there are a lot of great brands like I'm not sure how you say it, but Heine. There are several companies that are making Dermlights, and the Dermlight company is really expensive. So there are a lot of companies that are kind of bringing down the cost but preserving the quality. And there are cool attachments that you can kind of do on your phone. So I think whatever's accessible to you is a great start. I don't think the differences in quality, to my knowledge, are so superior that you really need to pick one brand over the other. But whatever gets a derm light in your hand and to help you and your patients, I think is the way to go.
That's great. Okay. Unless anyone else has any pressing questions, I will hand it back over to Neha. And then again, thank you both so much for all of your insight. I found this incredibly helpful myself, and everyone's asking for slides and recording, so I know everyone else also enjoyed it too.
Okay, everyone. We just wanted to say thank you to Dr. Hartman and Dr. Trepanowski for taking time out of the day to go over this amazing lecture. We also wanted to thank the audience for being here. And just a reminder, you can follow GlowDerm on social media to learn about upcoming events, webinars, programs, and more at GlowDerm Alliance on Twitter, Facebook, Instagram, and YouTube. I think the slides will be posted there as well. We also just want to say thank you to our supporters, CeraVe Care for All and the Ellis Foundation as well. Thank you all again for being here.